Good morning, friends. You are most welcome to Think Eyes channel. Today we are going to discuss Practicing Anthropology, which is written by IGNOU MAAN, and our topic is Epidemiology, Unit 3. Let us begin the topic. First of all, we will discuss contents. First is introduction. Second, definition of epidemiology, in which we will discuss determinants, health related states or events, applications, assessing the community's health. After that, we will discuss core epidemiologic functions, in which we will discuss public health surveillance, surveillance cycle, field investigation, analytic studies, evaluation, linkages, policy development. After that, we will discuss descriptive epidemiology. After that, we will discuss analytic epidemiology, in which we will discuss experimental studies, observational studies, cohort study, case control study, cross sectional study. After that, we will discuss epidemic disease occurrence. After that, we will discuss communicable diseases, in which we will discuss classification of communicable diseases, measures of disease in populations. After that, we will discuss the epidemiological transition, in which we will discuss demographic changes, changes in risk factors, biological factors, environmental factors, social, cultural, and behavioral factors, changes in community relationships, changes in lifestyle. After that, we will discuss non communicable diseases, their causes, and risk factors. At the last, we will discuss summary. Learning objectives are students who successfully complete this unit should be able to correctly describe key features and application of descriptive and analytic epidemiology, calculate and interpret ratios, proportions, incidence rates, and prevalences, describe the processes, uses, and evaluation of public health surveillance, and describe the steps of an epidemic outbreak investigation. Let us begin the introduction part. Epidemiology and anthropology share a common platform of work. They primarily focus on peoples living in groups, that is, as a community. Anthropology has four major subfields: cultural anthropology, physical or biological anthropology, prehistoric and archaeology, and linguistics. Branching out from these subfields are several subdisciplines that contribute much to the apprehensions of epidemiological objectives. Medical anthropology, which emerged as a rational subdiscipline in 1950s, rapidly materialized into one of the largest areas of research and practice within anthropology. Much of the work that concern epidemiology and hence public health surveillance finds its root in medical anthropology. The richness of this subdiscipline is obvious in the range of theoretical perspectives covered by it. Anthropology also made significant contributions to the field of epidemiology. The method of collecting field data and analysis in terms of descriptive, formative, and interpretive has been borrowed from ethnographic studies. The basic unit of study in ecology is the population, as it is in anthropology and epidemiology. The concept of health and disease in ecology is based on three assumptions. First is disease is the result of an imbalance in the ecosystem. Physical, biological, and cultural factors and their interactions are interlinked to maintain the subtle balance between health and disease. The ecological model offers a scaffold for the study of health in an environmental perspective, but it does not identify the factors that sustain health in a local system. A parallel practice of principles and methods of biomedicine and those of biomedical or biological and cultural anthropology can contribute to a better understanding of health and disease as dynamic, adaptive, population based processes. Anthropology addresses several questions about the effect of global political and economic structures and processes on health and disease. It works to extend the findings of medical anthropology by bringing the latter closer to the perspective of epidemiological research, which can contribute to the creation of large-scale health systems that can serve the people. James 2009. James 2009. Anthropologists study healthcare system at four levels to understand relationship between health and the participants of different population subgroups in a given social structure. First, individual level recording experience of the patients. Micro level studying the relationship between patients and physician. Intermediate level reviewing local hospitals and clinics. Macro social assessing the global political and economical effects on the healthcare system. Beliefs that relate infectious disease to paranormal phenomena, inequalities in the distribution and outcomes of infectious disease such as tuberculosis, AIDS, acquired immunodeficiency syndrome, and malaria, as well as social responses such as quarantine, often pose a challenge to anthropologists. Interpretative anthropology is an attempt to correlate individuals' experience of disease with the established description of the disease. The most important task of epidemiology is to find the root or origin of a disease and the effect of social factors, local and global inequities that affect the distribution of the same. The onset of a disease or outbreak of an epidemic is the result of several closely related factors one leading to another. One leading to another. A well designed evaluation system that targets these linked processes is needed in this regard. Anthropological theory and methods have immense to give to the field of epidemiology for effective implementation of suitable measures. Anthropology develops a subject or draws inference based on extensive fieldwork. This could include passive observation of the flow of events and or acquiring self-reported data by means of carefully designed questionnaires. This use of systematic, descriptive and qualitative methods to identify the context-specific factors in health and disease can contribute a great deal to the epidemiological research. A number of methodological benefits can be gained from combining anthropological and epidemiological approaches, including differences across cultures studied by anthropologists can be used to improve the development and measurement of epidemiological variables. Research results can be communicated more effectively to policymakers and to a public audience. Best measures of variability in culture and behavior can be developed. Ethnographic and epidemiological information can be used to design health surveillance systems and return data to communities in more comprehensible forms towards health and well-being. Can 2002. Definition of epidemiology. The term epidemiology has its roots in Greek, where the word epi means among demons, means people. The logos means doctrine. It originated more than 2000 years ago when Hippocrates observed the influence of environmental factors on the occurrence of disease. Epidemiology is defined as the study of the distribution and determinants of health related states or events in specified populations and the application of this study to the prevention and control of health problems. Last 1988. In the study of the communicable and non-communicable diseases, the work of epidemiologists ranges from outbreak investigation to study design, data collection and analysis, including the development of statistical models to test hypotheses and the documentation of results. Epidemiologists also study syndemic interaction of disease condition at population level. A systematic application of biology, geography, and social sciences tools enables epidemiologists to understand the etiology and risk factors of a disease better and to trace the spread of a disease across different geographical areas. Epidemiologic interferences rely heavily on data, therefore, a systematic and unbiased approach to the collection, analysis, and interpretation of the same is an absolute must. This is followed by comparison with valid groups to assess whether what was observed, such as the number of cases of diseases in a particular area during a particular time period, or the frequency of an exposure among persons with disease, differs from what might be expected. In other words, epidemiology deals with frequently or the frequency and pattern of the health events in the population. Frequency refers to the number of health events such as the number of cases of tuberculosis or diabetes in the population, as well as to the relationship of that number to the size of the population. The resulting rate allows epidemiologists to compare disease occurrence across different populations. Pattern refers to the occurrence of health related events by time, place, and person. Determinants. The term determinants refers to the factors that influence the term determinant refers to the factor that influence to develop a disease and other health related events. Several genetic, biochemical, environmental, and geographical determinants dictate the course of a disease. Analytical epidemiology is the tool of choice in tracing such determinants. Such findings provide data that can be used to prompt public health control and prevention measures. Health related states or events. Starting with only communicable diseases, epidemiology ended up encompassing non-communicable diseases also. By mid-20th century, additional epidemiological methods were created and applied to chronic diseases, maternal child health, birth defects, injuries, occupational health, environmental health, etc. Epidemiologists can also study genetic makers of disease risk by choosing any variety of technique from the repertoire of molecular biology. The term health related states or events may be seen as anything that affects the well being of a population. However, many epidemiologists still use the term disease to refer to the wide range of health related states and events that are studied. Applications. The entire community on the whole is considered as a patient in epidemiology, and therefore the conclusions drawn out of an epidemiological survey can be used to suggest suitable, realistic, and adequate public health interventions to control and prevent diseases. Assessing the community's health. Epidemiological research is the platform on which decisions on policy development, their implementation, and evaluation are made by healthcare professionals. The following questions are generally addressed to before developing policies. What are the actual and potential health problems in the community? Where are they occurring? Which populations are at increased risk? Which population have declined over time? Which one are increasing or having the potential to increase? How do these patterns relate to the level and distribution of public health services available? It is surprising to see how epidemiological information affects every individual's decision affecting health. The statutory warning of lung cancer on all brands of cigarette is a popular example. That cigarette smoke is a serious risk factor for lung cancer is a finding of epidemiological research in early as 1950s. In the mid 1980s, epidemiologists identified the increased risk of HIV, human immunovirus infection associated with certain sexual and drug related behaviors. The prime objective of epidemiology is to identify the factors that influence one's risk of disease so that suitable public health action might be taken. Core epidemiologic function. In public health practice, the core epidemiological functions are public health surveillance, field investigation, analytic studies, evaluation, linkages, and policy development. These tasks are described below. Public health surveillance. Public health surveillance is the ongoing systematic collection, analysis, and interpretation of data closely integrated with the timely dissemination of these data to those responsible for preventing and controlling disease and injury. Thacker and Barkelman, 1988. Public health surveillance is a tool to estimate the health status and behavior of the population served by ministries of health, ministries of finance, and donors. Because surveillance can directly measure what is going on in the population, it is useful both for measuring the need for interventions and for directly measuring the effects of interventions. The purpose of surveillance is to empower decision makers to lead and manage more effectively by providing timely, useful evidence. Subuga et al. 2006. Basic concepts. Indicator. It is a measurable marker that allows policymakers to estimate the burden of a disease in a community and assess the effectiveness of preventive steps. Action surveillance. It gathers information on population health on a regular basis with the help of healthcare professionals. Passive surveillance. The status of public health is interpreted from the records of hospitals, clinics, etc. Routine health information systems. It involves submission of reports on disease status by healthcare professionals, clinics, etc. Health information and management system. It acquires reports that allow planning of the administrative proceedings of healthcare system. Categorical surveillance. Attention is focused on one disease and its corresponding interventions program. For example, the HIV program. This can be done either by active or passive surveillance. Integrated surveillance. Several diseases and their intervention programs are taken into consideration at a single point of time. This can be done either by active or passive surveillance. Syndromic surveillance. Hence, information is collected based on symptoms of a disease under questions. Consequently, the data collected could include all possible cases that mimic the actual disease condition, which might not be as deleterious as the true disease. This is often the first type of surveillance undertaken in developing countries during an outbreak. However, the data is not specific and needs confirmation by appropriate methods. This can be done either by active or passive surveillance. Behavioral risk factor surveillance system. This method investigates into the unhealthy practices of the public that render it liable to a disease condition. For example, the number of smokers in the community. This allows the healthcare professional to address a disease at its very roots. This method is very effective in eradicating both communicable and non-communicable diseases. Surveillance cycle. Morbidity and mortality reports are common source of surveillance data for local and state health departments. These reports generally are submitted by healthcare providers, infection control practitioners, or laboratories that are required to notify the health department of any patient with a reportable disease such as meningococcal meningitis or AIDS. Other sources of health-related data that are used for surveillance include reports from investigations of individual cases and disease clusters, public health program data such as immunization coverage in a community, disease registries, and health surveys. While public health surveillance traditionally has focused on communicable diseases, now exist surveillance system now exists that target injuries, chronic diseases, genetic and birth defects, occupational and potentially environmentally related diseases and health behaviors. Field investigation. Upon receiving information from surveillance, the public health department can set to confirm or seek clarity in the report by phone calls or field investigation, which requires organized effort of dozens of people to characterize the extent of an epidemic and to identify its cause. Such inquiry often leads to the identification of additional unreported or unrecognized ill person who might otherwise continue to spread infection to others. For example, one of the hallmarks of investigation of persons with sexually transmitted diseases is the identification of sexual partners or contacts of patients. When interviewed, many of these contacts are found to be infected without knowing it and are given treatment they did not realize they needed. Identification and treatment of these contacts prevents further spread. Analytic studies. Outbreak of disease are often investigated initially with descriptive epidemiology. This is usually sufficient to identify cases, modes of transmission, and appropriate control and prevention measures. When the association between exposure and disease is reasonably strong, the investigation may stop when descriptive epidemiology is complete and control measures may be implemented immediately. John Snow's 1854 investigation of cholera is an example. Morris 1978 who said about that. But sometimes analytic studies employing more meticulous methods are needed in combination with surveillance and field investigations to evaluate the reliability of the hypothesis. The characteristics of an analytic epidemiologic studies is the use of a valid comparison groups. Epidemiologists must be skilled in all aspects of such studies, including design, conduct, analysis, interpretation, and communication of findings. Evaluation. Evaluation is the process of determining systematically and objectively as possible the relevance, effectiveness, efficiency, and impact of activities with respect to established goals. Effectiveness is the ability of a program to produce and propose to produce the proposed results in the field. Effectiveness differs from efficacy, which is the ability to produce results under ideal conditions. Efficiency refers to the ability of the program to produce the intended results within a minimum expenditure of time and resources. Linkages. Epidemiological field work is a team effort where an epidemiologist can either be the leader or a member of the team. The team members are often drawn from diverse disciplines like laboratory technicians, sanitarians, infection control personnel, nurses, or other clinical staffs, and increasingly computer information specialists. When the outbreak under investigation encompasses different geographical areas, the co-investigators may be from local or state levels of government, academic institutions, clinical facilities, or the private sector. To promote current and future collaboration, the epidemiologists need to maintain relationship with the staff of other agencies and institutions. Policy development. The once popular recommendation that epidemiologists should not get involved in policy development has been put to rest now. Certainly, epidemiologists who understand a problem and the population in which it occurs are often in an outstandingly qualified position to recommend appropriate interventions. As a result, epidemiologists working in public health regularly provide input, testimony, and recommendations regarding disease control strategies, reportable disease regulations, and healthcare policy. Descriptive epidemiology. A descriptive study is often the first step in an epidemiological investigation which involves description of the occurrence of a disease in a population. A simple description of the health status of a community based on routinely available data or on data obtained in a spatial survey is often the first step in an epidemiological investigation. The link between exposure and effect is not addressed in these studies. The pattern of death against parameters like age, sex, etc. in various countries at specific times will be observed. An example of a descriptive study is shown in the figure 3.1 and 3.2, which chart the burden of COPD in India from 1995 onwards. The data below shows that the number of the patient with COPD, which was around 95 lakhs in 1995, is expected to rise to 165 lakhs by the year of 2020. Moreover, adhering to the prescribed treatment strategy could cut down the annual expenditure from 48,000 crores to about 566 crores. Such data help healthcare professionals prioritize and also take necessary steps to minimize the economical burden. This is the graph which is shown here. Here you can see urban. At the bottom you can see the line to describe the urban in lakhs, urban population, and above line which describes rural population in lakhs. Estimated numbers of patients in lakhs with chronic COPD in India modified from Murthy and Sastry 2005. Here is one more graph, comparative treatment cost of COPD in India, rupees in crore, modified from Murthy and Sastry 2005. Dark line shows amount, rupees in crores, current treatment, and light line shows treatment according to guidelines, amount, rupees in crores. Analytic epidemiology. An analytic study evaluates the relationship between health status and other variables. The characteristics features of analytic epidemiology is a comparative group. An outbreak of hepatitis A in Pennsylvania in 2003 can be cited as an example. It was discovered that all the people infected had eaten at a certain restaurant 2 to 6 weeks prior to the onset of the disease. However, the investigators could not attribute this to the contamination of any one particular food item. In order to investigate into this, the researchers inquired a group of people who had eaten in the same restaurant at the same time but did not get sick. Of 133 items on the restaurant's menu, the most striking difference between the case and control groups was in the proportion that ate salsa. 94% of case patients ate compared with 39% of controls. Further investigation of the ingredients in the salsa implicated green onions as the source of infection. Shortly thereafter, the Food and Drug Administration issued an advisory to the public about green onions and risk of hepatitis A. MMWR 2003. Experimental studies. Experimental epidemiology involves testing the effect of a change in a variable on group of people. The effect of such an intervention is measured by comparing the outcome in the experimental group with that in a control group. Experimental studies include, for example, in a clinical trial of a new vaccine, the investigator may randomly assign some of the participants to receive the new vaccine while the others receive a placebo shot. Placebo, that is a sugar shot. The investigator then tracks all participants, observers who gets the disease that the new vaccine is intended to prevent and compares the two groups, new vaccine versus placebo, to see whether the vaccine group has a lower rate of disease. Similarly, in a trial to prevent onset of diabetes among high risk individuals, investigators randomly assigned enrolls to one of three groups: placebo, an anti diabetes drug, or lifestyle interventions. At the end of the follow up period, investigators found the lowest incidence of diabetes in the lifestyle intervention groups, the next lowest in the anti diabetic drug group, and the highest in the placebo group. Randomized, randomized, randomized control trials. Subjects in the study population are randomly assigned to interventions and control groups, and the results are assessed by comparing outcomes. Field trials. Field trials, in contrast to clinical trials, involve people who are healthy but presumed to be at risk, since the subjects are disease free and the purpose is to prevent disease that may occur with relatively low frequency. Field trials are often logically complicated and expensive endeavors. M. Deepa and others, 2011. Community trials. In this form of experiment, the treatment groups are communities rather than individuals. This is particularly appropriate for diseases that are influenced by social conditions and for which prevention efforts target group behavior. Bonita, R.R. Beaglehole, and T.K. and T. Gelstrom, 2006. Observational studies. In an observational study, the epidemiologist simply observes the exposure and disease status of each study participant. The common types of observational studies are cohort studies, case control studies, and cross-sectional studies. Cohort studies. In a cohort study, the epidemiologist records whether each study participant is exposed or not, and then tracks the participant over the period of time to see if they develop the disease of interest. If the disease rate is significantly different in the exposed group compared to the unexposed group, the exposure is said to be associated with illness. These studies are also called prospective cohort studies because participants are followed prospectively after enrollment over time to identify occurrence of the outcomes of interest. In retrospective cohort study, both exposure and the outcomes have already occurred, and the investigator calculates and compares rates of disease in the exposed and unexposed groups. In retrospective cohort studies, the inquiry moves back in time. Case control studies provide a relatively simple way to investigate causes of disease, especially rare diseases. They include people with a disease of interest and a suitable control group of people unaffected by the disease. The study compares the occurrence of the possible cause in case and in controls. Cross-sectional study. In cross-sectional study, the measurements of exposure and effect are made at the same time. Cross-sectional studies measure the prevalence of disease and thus are often called prevalence studies. It is not easy to assess the reasons for association shown in cross-sectional diseases or cross-sectional studies. The key questions to be asked is whether the exposure precedes or follows the effect. In sudden outbreaks of disease, a cross-sectional study to measure several exposures can be the most convenient first step in investigating the cause. Data from cross-sectional studies are helpful in assessing the healthcare needs of population. Now we will discuss epidemic disease occurrence. The amount of a particular disease that is usually present in a community is referred to as the baseline or endemic level of the disease. Some diseases are so rare in a given population that a single case necessitates an epidemiologic investigation. Example, rabies, plague, polio. Other diseases occur more commonly so that only deviation from the norm demand investigation. Sporadic refers to a disease that occurs infrequently and irregularly. Endemic refers to the constant presence and or usual prevalence of a disease or infectious agent in a population within a geographic area. Hyperendemic. Hyperendemic refers to persistent high levels of disease occurrence. Occasionally, the amount of disease in the community risk above the expected level. Epidemic refers to an increase, often sudden, in the number of cases of a disease above what is normally expected in that population in that area. Outbreak carries the same definition of the epidemic but is often used for more limited geographic area. Pandemic refers to an epidemic that has spread over several countries or continents, usually affecting a large number of people. Communicable diseases. Communicable diseases are infectious diseases that can spread from one person to another or from animals to people through a microorganism or its product. These diseases affect people of all ages but more commonly children due to their exposure to environmental conditions that support the spread. Well planned interventions can put a check to the spread of communicable disease. Classification of communicable disease. Communicable disease can be classified into different ways as follows. Contact disease, example scabies, fungal skin infection, acute bacterial conjunctivitis, and sexually transmitted disease. Conjunctivitis. Contact disease, example scabies, fungal skin infection, acute bacterial conjunctivitis, and sexually transmitted disease, STD. Vector borne disease, example relapsing fever, yellow fever, plague, and malaria. Disease caused by fecal oral contamination. Acute gastroenteritis, bacillary dysentery, amoebiasis, अमीबा से होती है ये. Cholera, enteric fever, and food poisoning, etc. Helminthic disease, example ascariasis, enterobiasis, trichuriasis, and hookworm. Airborne disease, acute respiratory infection, like asthma, and meningitis, bacterial and fungal, tuberculosis, and leprosy. Zoonotic diseases, disease of contact with animal or animal products, example anthrax, brucellosis, rabies, hydatidiosis, and tetanus. Measures of disease in populations. Epidemiologists consider the following factors to measure disease frequency in the population: number of people suffering from the disease, size of population which harbors the disease, time for which the population has been followed. Disease occurrence is measured and compared using ratio, proportion, and rates. A ratio is the output derived by dividing one number by another number. For example, the sex ratio 0.9/1 means 900 females for 1000 male. 900 upon 1000 means 0.9 upon 1. 0.9 is to 1. The numerator of a proportion is always a split of the denominator. For example, the proportion of people belonging to a particular caste A is the number of people belonging to caste A divided by the total number of people in a community or predefined geographical area belonging to all castes. While reporting rate, time is an essential part of the denominator. For example, the occurrence of a disease in a country can be reported as 400 cases over 1 lakh population per year. Other aspects taken into consideration to check disease occurrence in a population are frequency measures in the population. Incidence and prevalence are the two basic measures of disease frequency in epidemiology. Incidence is the frequency of a new disease and prevalence is the frequency of current disease. Cumulative incidence, it is the proportion of a candidate population that becomes disease over the specified period of time. Incidence rate, the incidence rate is measured of the frequency with which a disease occurs in a population over a specified period of time. Prevalence, it is the ratio of the number of occurrences of a disease to the number of units at risk in the population during a given time period. Incidence rates help us to know how fast the disease is spreading, infecting or affecting people. Incidence and prevalence are two distinct measures of disease frequency and hence should be used with causation. Incidence measures the rate of occurrence of new cases in the population, whereas prevalence measures of the total number of cases of disease in a population. The epidemiological transition, the occurrence of a shift from infectious to non-infectious disease or vice versa is equally likely. In other words, the epidemiological transition need not be unidirectional. In fact, it is a continuous transformation process with some disease disappearing and others appearing or re-emerging. Several factors like demographic, socioeconomic, technological, cultural, environmental, and biological changes dictate the course of events. Demographic changes as population become healthier in response to certain intervention measures. One can see a fall in infant mortality rate. More people will survive to adulthood and will have the disease patterns of adults with non-communicable diseases like cancers and cardiovascular disease at the top of list. Thus, even with constant age-specific incidence rates of non-communicable diseases, the absolute number of cases and deaths from these diseases increases substantially with the changes in demographic structure. Vahadan, 1996. Changes in risk factors. The risk factors involved in the epidemiological transition include biological factors, microorganisms, environmental factors, social, cultural, and behavioral factors, and the practices of modern medicine. Biological factors. Microorganisms have a tremendous ability to adapt and hence survive. The development of mechanisms that permit survival of the most adaptable microorganisms is more rapid than the development of defense mechanisms that allow their host to combat microbial invaders. This poses a challenge to medicine when antibiotic or drug resistant strains continue to evolve. Here we will use super drugs like cholesterol. Environmental factors. Cleanliness and hygienic lifestyle. Cleanliness and hygienic lifestyle is the paramount importance when it comes to keeping communicable and non-communicable disease at bay. Environmental factors may increase the incidence of infectious disease if they offer opportunities for transmission of etiological agents from the reservoirs of the infection to susceptible host. For example, by promoting breeding of vectors of diseases or because of overcrowding. For example, disease such as typhoid can be controlled by ensuring supply of water free free from sewage contamination, discharge of industrial effluents into soil, water, or air is the reason behind the increase in some diseases such as various types of cancer and chronic chest conditions including asthma and chronic bronchitis. Social and cultural and behavioral factors. Social, cultural and behavioral factors are closely related and interlinked. The shift from an agricultural to an industrial society and its accompanying processes of modernization produce changes that affect people's health. Vahdan, 1996. Changes in community relationships. Modernization, which renders individuals busy from dawn to dusk, has erased the family culture where family members could share sorrow and happiness to alleviate stress. An evident example of maladjustment due to urbanization is the traumatic encounter of rural youth with urban values. This frequently has a serious impact on mental health. Another domain that has been seriously affected is the care of elderly. The elderly are now cared for away from their families in homes for the elderly. Changes in the lifestyle. This is intimately related to modernization. Several prospective studies emphasize that the lifestyle, conditions of life, and the way of people live and work have been a cause of many diseases, particularly non communicable diseases. It is commonly used in a restricted manner to mean specific individual behavior patterns that are interpreted as risk factors. Thus, lifestyle refers to the manner in which the social group translates its situation into a pattern of behaviors that produce what are called behavioral risks. For example, to cope up with the busy schedules, people have begun to prefer fast foods over home cooked meals. Mass media, television, radio, newspaper, journals, magazine, books, etc. is one of the important elements in making several behavioral changes in lifestyle, social behavior, and social value system. Media influences is so powerful that it could be rightfully said that the public is almost completely controlled by the media. Simultaneously, mass media's negative influence on health comes from advertisement for commodities that are not necessarily needed by the community, but the latter is made to believe that what is advertised is needed. Ibid, a particularly destructive, a particularly destructive example is tobacco advertising, which was very extensive a few decades ago and helped establish this hazardous habit. Its root became well fixed in communities who thought that smoking would make them appear modern and advanced. This has greatly contributed to increase in non-communicable diseases. Non-communicable diseases, their causation and risk factors. A non-communicable disease is non-infectious. They include heart diseases, stroke, cancers, chronic kidney diseases, diabetes, osteoporosis, Alzheimer's disease, cataracts, asthma, etc. Risk factors include age, example Alzheimer's disease, sex, prostate cancer, genetics, Down syndrome, exposure to air pollution, asthma, COPD, lung cancer, and behaviors such as smoking, unhealthy diet, and active, physical inactivity, which can lead to hypertension and obesity, in turn leading to increased risk of non-communicable disease like diabetes. The 5 important risk factors for non-communicable disease identified by WHO's World Health Report 2002 include raised blood pressure, smoking, alcoholism, raised cholesterol, and overweight. Socioeconomic conditions are also also are associated with higher risk of non-communicable diseases. The general statement once prevailed is that non-communicable diseases were confined to developed countries and communicable disease to developing countries. The general statement once prevailed is that non-communicable disease were confined to developed countries, non-communicable, and communicable disease to developing countries. The burden of disease attributed to NCDs has been estimated at 85% in industrialized nations, 70% in middle income nations, and nearly 50% in countries with the lower or the lowest national incomes. Recent estimations indicate that NCD accounted for more than 60%, over 35 million of the 57 million deaths worldwide. Given the global population distribution, almost 80% of death due to the chronic NCDs worldwide, non-communicable diseases worldwide, now occur in low and middle income countries, while only 20% occurs in higher income countries. National economies are reportedly suffering significant losses because of premature deaths or inability to work resulting from heart diseases, stroke, and diabetes. Summary: as the basic science of public health, epidemiology includes the study of frequency patterns and causes of health-related states or events in populations, and the application of that study to address public health issues. Practicing anthropologists with a background in public health studies and epidemiology can act as epidemiologists and use a systematic approach to assess the what, who, where, when, and why, how of these disease or these health states or events. Two essential concepts of epidemiology are population and comparison. Core epidemiologic tasks of a public health epidemiologist include public health surveillance, field investigation, research evaluation, and policy development. In carrying out these tasks, the epidemiologist is almost always part of the team dedicated to protecting and promoting the public's health. Epidemiologists look at differences in disease and injury occurrences in different populations to generate hypotheses about risk factors and causes. They generally use cohort or case control studies to evaluate these hypotheses. Knowledge of basic principles of disease occurrence and spread in a population is essential for implementing effective control and prevention measures. Thank you very much.